the aim of this debate is to see the variation in practice related to some ethical and maybe have also legal issues for some IVF practice. We will have like three different topics. One related to the sex selection, and one related for the patient who intended to or wants to have multiple pregnancy and comes to us. And the third one is related to some interventions that we know by heart now that it may not be beneficial, but the patients wants this intervention. And we have experts from all the globe now, from Saudi Arabia, Dr. Fawaz, Medical Director of Jeddah branch, Dr. Macklon from Copenhagen University Hospital, Dr. Buhaira from Sulaiman Al Habib, Dr. Majid Al Aoum from Mediclinic Borno Hall Al Ain, Dr. Wael from Health Plus, and also Dr. Yaqub, I think he will join us now, and Dr. Prolio. So we can, what we can do is to have the question and see how is the vote is running toward which side, and we can have comment from the experts, and all the comments is related more or less to ethical parts, and do you feel you comfort to encourage the patient to do, or you cannot accept, or what is the situation? Generally, is it the patient right to choose the sex of her baby for non-medical reason? We need to vote, please. Anyone is voting or no? We can hear opinion from Dr. Yao. Where is Dr. Yao? What do you think? Is it the patient right to choose the sex for her baby for non-medical reason?
So the patient has always the right to choose as she wishes. The professional has obligation to abide by whatever belief they have, whatever ethical framework they work under. I give an example. I work in the United Kingdom, where the society decided sex selection is not on. End of the matter. I have patients almost every day who indirectly, a bit slightly reluctantly, they will bring it into the discussion. And the line is ready. We do not do sex selection in the UK. That is the society's choice. I don't judge it whether it's right or wrong. If I work in other societies, and I should not have made that mistake of making that hypothetical assumption, if a patient has two daughters, and she's coming to have IVF and she would like a son, I don't see anything wrong with that. But I see at personal level, without judging people, if people insist on having a male child or a baby from the first attempt at IVF, that is where I stand. Yeah.
Dr. Fawaz, what do you think in Saudi?
Well, I concur with Dr. Yaqub's comment that the patient has all the right. I mean, from my prospect, I have no problem. I think as long as the patient knows the possibilities and the chances. Yeah, I look at it from a religious point of view, and I'm sure we have all different probably backgrounds or beliefs, but I believe that if a family is meant to have a boy or a girl, they're meant to have that boy or girl. Our job is just to ناخذ بالأسباب, to take, to run with the reasons or the ways, and from what we learn and what we know. At the end of the day, if it's not meant to be, it's not going to happen. Even if you put back a boy, and she's not meant to have a boy, she's not going to get pregnant, or she's going to have a miscarriage, or the boy is going to die, or something. So I have no objection in helping any family, even if it's their first pregnancy.
Let's make it difficult. A patient comes to you and you want to have a boy, and you make a treatment, and she has all embryos are females. And she's asking you to discard the females and start a new cycle. Because
Right.
this discussion, we had it very often.
Right. I think it's all to do with the counseling that you did initially. I'm just going to talk to the audience, if you don't mind. So it all depends on the counseling you did at the beginning. So if you were very clear, I mean, in Arabic, they use the term tahdid jins. And I tell them, no, it's ikhtiyar jins. So they use, I don't know what's tahdid in English, but I tell them it's ikhtiyar. Ikhtiyar means we select. So I tell them very clearly that we take the eggs, the sperms, we put them together. God creates the embryos. God decides it's a boy or a girl. Our job comes into testing these embryos and finding out if it's a boy or a girl, and then putting that embryo, based on your choice, back to the uterus. Whether you get pregnant or not, that's also God's choice. But if God decided you're going to get pregnant, then you're going to get pregnant with the sex that we have chosen. So if I'm very clear with that, that it's a selection. I think the acceptance rate is very high. We do a lot of sex selections cycles in Saudi Arabia. We get patients from the UK as well referred to us. And satisfaction is good. We face few issues at the beginning, but with more awareness of the population and their understanding that it's a selection, they accept the outcome even if all the outcomes were girls. It still hurt them when they know the information. Nothing against the girl, but even it's the other way around. If they wanted a girl and they have a boy, so it still hurt them, but they do accept it.
Very nice. Dr. Wael, the same question, how are we going to do it?
The patient always has the right to choose. However, we as clinicians, we have to abide with the local regulations and laws. I have here the Arabic and the English version of the IVF law, and to your knowledge, the Article 14 that addresses the genetic testing talks about exclusion of abnormal embryos. It does not address the sex selection at all. And when it comes to treatment, it says also in Article 4 and 5 that the couple have to be infertile for some time, like 1 year, unless they have a definitive reason that they need treatment earlier. So there is another statement about the executive decree that should come to explain the law in more details. And the first trial to tackle this issue was from the government center in DHA. When the first version of the law came, we addressed the question to the legal department. I was working there at that time. And the legal department took the question to the Council of Fatwa, the Islamic Council for the judgment. And the Council of Fatwa replied back that, yes, you can do the test within the context of excluding medical disorders and for non-medical reasons for family balancing only. And what does family balancing mean? That the couple, or the married couple, should have a prevalent sex in the family to ask for another one, a different sex. So when I have a couple, they come to me, they ask this question of this service, I would always ask myself, are they infertile that can go under the law to be treated? Are they abiding with the statement that it is for family balancing or not? And I want also to highlight that the law talks about married couple, not about a family, which in other words, you can have a man married to 2 wives. One has got 5, 6 girls, and the other one, he's newly married to another one, and they have tried for 1 year. Pregnancy is not happening, and he's coming to ask for a boy. I say, I'm sorry, this does not comply, although he has 5, 6 girls from the first wife, but the second wife doesn't have any kids. So it's not fair that I give her a stimulation protocol, put her into risk the minimum of it, that she will get fibroadenosis in the future or can get ovarian or breast cancer, and later on in the day, I discard female embryos and not to transfer to her. So I say to him, this does not comply with the rule. I would love to help the families and fulfill their wish, but as long as it complies with the current regulation. So, main question for me, do they need the ART to get pregnant or not? Second, do they fulfill the statement of having a prevailing specific sex in the family or not? If these are fulfilled, then I will go ahead and help them to get what they wish.
Thank you, Dr. Wael. I actually facing sometimes very difficult scenarios. This one of them, when we have a woman has 3 boys and wants another boy, and I like Dr. Buhaira to help me to solve this problem for the patient.
So you've given me the most difficult and challenging one, Ahmed, but okay. So she's got 3 boys, and wants another one.
Yes.
To be honest, yes, we do discuss and say that the patient has the choice to choose, but you are there to guide, you are there to provide the information, and you should be able to ask and find out what is the rationale behind it, why is that, were the previous pregnancy spontaneous or were the ART as well, and what is the rationale behind the 4th baby. This is called family balancing. So if you're going to balance the family, then the missing gender is the one that you're going to do. There are lots of doctors out there, and it's going to be very much personal, depending on the law of the land, where you're practicing, culture as well. Personally, if she's coming to me and she has 3 boys and wants a 4th, I need to understand a little bit, it's not a no, but I need to understand a little bit more what's the rationale behind that. I'm not sure that I would go ahead with that because it's not family balancing.
To have more boys.
All boys, I can't do that.
You will refuse.
I would not.
Me, I refuse.
I
Like
would
this
not.
later cases for practicing UEE. What do you think, Dr. Walid? You refuse or not?
I think this is, you have to convince a patient that this is the wrong decision. So I think you cannot leave the patient like that and tell her, I cannot do it. You have to talk to her and explain to her that it's unnecessary risk to go through a procedure. And if you go to a spontaneous conception, the probability is very high to have another boy.
If she has a problem for IVF and she will do IVF and she has 3 boys and also insisted, Dr. Brolio, what do you think?
Well,
she has 3 boys
yes,
and she has tubal block.
When
and she
we
needs
analyze,
another boy.
here we're talking about ethics, right?
Yes.
Okay, so when you analyze an ethical problem from an ethics point of view, I'm not talking about the law, I'm not talking about religion or other points of view. And of course, I'm not the one who has to analyze the motivation for the patient, right? That's not my role. Again, when we analyze from an ethics point of view, any medical problem, we have to attend to the 4 basic principles of the ethics in medicine. The principle of beneficency, the principle of non-maleficency, principle of autonomy, and justice, these 4. So if you apply these 4 principles, beneficency, there's a benefit for the couple, clearly. The embryo, and here comes everything with the status of the embryo, is not a human being. I'm not saying it's a human being in potential. Potentially, she is, or it is, but it's not a human being. So we cannot apply the same rules that for those applied for a human being. Has a special status, like happens, for example, in Europe, okay? So there's no, in terms of beneficency, clearly it is. There's no maleficency, because there's nobody else who is damaged because of that decision. There is autonomy, because the patients are autonomous to take that decision. And finally, the principle of justice is the only one which maybe cannot, because it has to do with the access to healthcare, to be fair with, let's say, to avoid people who don't have the ability, financial ability to access to healthcare to go through it. And because we can raise many ethical problems here, but particularly in this case, as far as the law doesn't say anything against it, it is absolutely legal, right? I don't think that we have to be the judges of the patient's motivations, honestly.
Thank you. Dr. Magid, I would like to ask you a question which we are facing every day in our clinics. The patient comes to have a boy, and by the PGTA, we have already one boy, one girl, so you decide to transfer the boy, but the quality of the embryo by the female is much better. The quality of the embryo of the male, you are expecting actually for a poor implantation. What you will decide?
We'll go back really to the same points. I mean, what's the motive? She wants a boy, say for example, is there any medical or only purely social reason? How many children does she have before, boys or girls? I mean, obviously, having the girl of a superior quality doesn't mean we have to transfer the girl. I mean, usually, I must say, I do advise them to have both transferred, have two embryos. I'm still from the people who still transfer two embryos, and I don't feel ashamed about it. I rarely do single embryo transfer. I feel, in most cases, I feel patients wants to have more one child. Risks are not that high. Risk of twins are high, so I go for transferring two. I try to convince, obviously, in that case, you cannot force patient to have an embryo against her will, but I mean, it's quite difficult. You could just talk about it.
Dr. Walid, I had that scenario, and I will tell you what happened. So she had one boy and maybe 3 girls, and the top embryo was certainly not a boy. And I knew this patient for years and been managing her, and I talk to my patients, Braulio, and I find out about their background, and they are very open with me. And she came to me and she said, "Doctor, I am in dire straits. I know I have all these better embryos, but I may not be able to get pregnant again, and maybe this is my only pregnancy. Please, would you be willing to put back this boy for me?" And knowing full well, and after proper full counseling, that this is not the best decision that you would do. Now, we take into consideration the law, we take into consideration choices, we take in consideration a lot of things, but what we need to take in consideration, the person in front of you and the impact of your decision on her future life. I know if I transferred back a female, first of all, she wouldn't have come back to me. Second of all, she wouldn't have a husband, and the child would not have a father. So we have to take into aspect everything. We have to discuss it, so a bigger picture. We need to look at that. This patient, I transferred the weakest of the 4 embryos. She got pregnant. She's halfway through her pregnancy. And I'm quite happy with the decision, because I saved 2 lives, not just 1.
Okay, I may update you about the voting.
Was she a case of family balancing, or?
No, she did PGTA because she wanted to make sure that her embryos were normal. And so she, when she found out the result, she said, "Can I have my first choice as a boy?"
Okay. Now, you are working in Dubai under the jurisdiction of DHA. If this is not a case of family balancing and you have an audit, you might be questions about it.
This patient, I'm very happy to support my decision for this, because they can question me and I can tell them I've either do not do what she wants and she can go around to other clinics, and I know her personal circumstances very, very well. I will put forward her social case there, and in every law there are caveats, there are the addendums and whatever, but I'm more than happy to be questioned and audited by the DHA and to be asked, justify this decision and why you did it. So and that would be my rationale, and I'd be more than happy to discuss this and defend my position.
Then we can bend the laws and regulations and go ahead and transfer 3 embryos, although we all know with all the, again in the law, it does not say how many to transfer.
That's a very different issue. No, it's a very different issue, because if you put 3 embryos there are medical risks related to that. There are no medical risks related to the decision I have made.
The law does not say how many to transfer, but we all know that we got subsequently a memorandum that we are not allowed to transfer more than 2 embryos. Now, you can say whatever you said just right now, no, I want to transfer 3 embryos for this lady and I have my own reasons. Again, this is going to be bending.
It's not bending.
It is
Because if
bending
you-
of the
no,
regulation.
it's not. Because if you transfer 3 embryos, you're putting this patient at risk by getting multiple pregnancies, and there are medical fallout from that. Whereas in the other situation, I am not harming anybody else. I am probably saving that patient's future social life.
We want to be productive
So
in our
that you
discussion.
cannot,
You are not harming the
compare
patient.
apples
You
with
are not
pears,
harming
Dr.
the
Wael.
patient,
I'm so
yes,
sorry.
but you are opening the door.
Thank you.
You are opening
Please,
the
a
door.
round of applause.
Guys, the fine in the law is 500,000 dirhams. I'm not talking from no reality here. I have got the version, Arab English, who wants to read it, please.
Are we discussing regulations or we're
It's-
discussing ethical?
No,
It's actually
is
the-
a regulation.
We're
And
discussing
ethically,
ethics
you see,
and
Fawaz,
within the law where I am
am
practicing.
I am happy to do whatever the patient wants, but within the context of the regulation, I cannot bend them. As Dr. Yaqub said, in England, there is no sex selection. There is no sex selection.
Right.
You can't.
I'm just asking, are we discussing today the ethical?
No, we are
Aspects.
discussing real scenarios that happened
Because
every day
the
that we are
situation,
facing.
I think if we ask someone who works in a country where they allow it, would he or she support it or not? Not the
Yes.
other way around, because the regulation. at
Let's
the end of
do
the
it
day will
like
win.
that. Let's do it like that.
Yeah, do it
Let's
like
do
that,
it in
you know,
an ethical view.
Internationally, every country has got its own regulations, and I'm happy to help the patient as long as I'm working within those regulations. And
But this is not the point, Dr. Wael. We want to know the ethical issues, how you feel ethically from deciding to transfer
Is it,
a bad
is
quality
it
embryo
ethically,
over the...
Dr. Waleed, to transfer 3 embryos or not?
No,
Is it
it will
ethical?
come in the discussion.
Because everything is arguable. You know, if you say, yes, I'm happy to transfer 2 or 3 because the risk for multiple pregnancy is low. Yeah, but when you face a case with triplets triplets. I had triplets. She begged me for 1 month to put the 3 embryos, only 3 embryos left for her after many tries.
One brief comment about this particular point. Because nowadays, to transfer 3 embryos is not only a matter of regulation, could be considered a malpractice.
Even twins.
Yes,
Even twins.
I agree.
Now,
That's why.
now the rationale for the DOH that if you get someone pregnant with non-identical twins, this is counted against you. It makes the coefficient factor for you to go down. Why? Because we are thinking from the patient perspective and the doctor perspective. What about the state perspective? The people who put this regulation.
But clearly here, this is a very good example to compare the different principles of ethics. Let's say that you have the same frameworks legally for sex selection and for embryo transfer. Let's say we will compare 2 countries. Country A, in which there's no limit for the number of embryos to be transferred, like in the US, in most of the states of the US, and there is no limit for sex selection. Another country where you have a limit for sex selection, okay, it is not allowed, like happened in Spain. When you receive a report from genetics lab, they don't disclose the sex chromosomes. They say euploid or not euploid. And there's a limit for the embryo transfer, like happens, for example, in Denmark. It's only allowed to transfer one embryo, okay? So, from the ethics point of view, if you are in country A, USA, okay, and you have 3 beautiful, good quality embryos for a patient who having through the first IVF attempt, and you transfer 3, that's malpractice. No matter what the regulation says. Because if you finally end up in a court, nobody will defend this 3 embryo transfer. Whereas for the sex selection itself, right, as far as it is allowed, there's an ethical debate, because the question here is who is endangered due to that embryo transfer or due to that decision? Whereas the problem or the person who takes any kind of bad side with that selection. Is there any lack of autonomy for the patient? Is there any other problem beyond that? So it's the ethic. I think we cannot mix up law. Law is something different. Of course, you have to be always under the law. Ethics is one step further, and in between, we have to consider things that, even though maybe under the law, can be considered as malpractice. So I think we
I
have
agree.
to fix.
Please, last comment from Dr. Yaqub
Yeah.
to go for
I
another
can't
point.
comment whether you should give her or don't give her because this I don't have experience with. I'm just using the opportunity to share with you that in any organization, there will be some contentious scenarios like this, controversial. It's not fair on individual clinician to make those decisions and come against criticism of another fellow clinician. What is helpful in this situation, where there is a precarious situation like that, there must be a common meeting for some forum within the group. That's what we practice. Every week we have a team meeting at Friday lunchtime meeting, and there is a section for any case for discussion, a patient where we have some issue about the welfare of the child, because that's expectation by law. A patient who's asking for treatment that we may not be feeling happy because the guy had some conviction, all of that. And occasionally we have situations where we have to refer the dispute to the hospital ethics committee. This is a functional way of tackling this because you cannot really put the burden on one individual to make a decision and then it will be to the liking or disliking of another member of the team.
Okay, thank you very much. There is answer from the attendee about the method of sex selection, and 17% choose something other than BGTA, which I need to, we have all يعني, IVF experts from all over the world. There is no guarantee for traditional methods, for IUI, sperm sorting. This shouldn't be done and shouldn't be encouraged by all gynecologists. May we go for the second debate? And lastly, I also want to you prepare the second debate. What's your opinion for sex selection and what's happening in Denmark?
Oh, you're asking.
Go for the second debate.
So, the first question was, is it the patient's right? And I just want to add a little comment on that, because what is the definition of right? So you have rights and you have possibilities. So you have human rights. It's a human right to have access to fresh water. It's a human right to have food, etc. Is it a human right to decide the sex of your baby? So that's a definition. I don't think it is, but we can all have different opinions on this. Now, the possibility to have sex selection is not, it's not a possibility in my country. It's illegal, like in the UK. In fact, when we do offer aneuploidy screening, etc., to the patients, PGTM, we're not allowed to disclose the sex of the baby.
Thank you.
Yeah. I work in a public setting. I work in a large university hospital clinic, completely sponsored, funded by the government. I do not work in a private clinic. I think if you, let's say sex selection was allowed in Denmark, in my country. Now, do you think it's reasonable to spend everybody's money, because it's everybody's money, it's what we pay. We have a very high tax, probably the highest in the world. Is it reasonable to spend some of that money on selecting the sex of the baby? Or should you rather spend the money on helping as many infertile patients as you can have a healthy baby regardless of the sex?
In a public setting, the answer is very, very clear. The benefit is for the vast majority of infertile patients. Because if you check this from the basic ethics principles, there is a maleficency for the patients who are private of these treatments because they don't have the chance, because their resources are devoted to something which is not necessary. So in a public setting, 100%. I totally agree with you. And this would happen in most of the public settings funded IVF. Well, you are assuming, you are taking, or again, but they are assuming and talking about the assumption that this may have an impact on final, let's say, the final percentage of males and females of the society. But let me tell you something. Let me give you another side and another view of this. I guess that you're aware of the policy, the single child policy that China has been for years and in there, right? For whatever the reason, in the Chinese culture, this, the first baby to be a male is very important. So what was happening in rural areas in China? They were killing the girls at birth. They were burying the girls, and then they were having another chance to have the baby boy. And finally, they had the baby boy. As a consequence of this and the single child policy, do you know what's the difference now in China between the males and females in reproductive age? 25 million. So there are 25 million excess of males over females now in China as a consequence of this. So do you think that, and you have the other example of India. For years, the best business in India has been to have a clinic to diagnose the sex of the baby here and to make a termination in the next door to when they was female. Am I right? So when there is a demand, you have to think in the less damage, let's say, for the way in which the patients, because at the end, it's like water. You cannot stop it. If there is a social demand, they will search for the way to do it. And I think that it is better to regulate rather than setting a ban in something that in certain places, culturally, may be a demand.
I'm sorry to interrupt, but we need to go for the second part, which is related to patients who are keen to have twin pregnancy. And we are facing every day, and we have some of them make official complaints against us. We started with one scenario for the audience who wants to have twins, and some of them offer induction of ovulation, which can be uncontrolled. For me, it can be a dangerous behavior. But what's your opinion, Dr. Yaqub, for who wants to have twin pregnancy?
I am just feeling a bit of unease about speculating about a situation that I don't practice within. There is nothing called she wants. There is something called you are responsible for giving the patient your input into giving her the best possible outcome. And there is no question, however belittling we do about the risk of multiple pregnancy, there is no question that singleton pregnancy is safer than twin pregnancy. So I would not be accomplice to give the patient a recipe for disaster. Admittedly, say 10% of the twins will deliver very prematurely. Would I be responsible if that baby developed cerebral palsy later? It's just sometimes I feel under certain pressures of different nature that we find the easy option is to accede to patient demand and say she wanted twins, there is no harm, I can give her. And there are two things again is that. As an important ethical principle is, just because we can, it doesn't mean we should. That's number one. Number two, where there is harm, our priority is to avoid harm rather than to satisfy the benefit of this patient. The third one, which is important in this equation, and I don't mean to be accusing anyone of different attitude, there is the element of fear that this patient, if she was not given this, she will go to another clinic is prominent here and play a major part in making decisions. But for me, within the confines of my office, I will tell the patient what I always believe to be in her best interest, communicated in the best possible way, and if she wanted to go somewhere else, I feel, I'm not being arrogant, if not listening to me is a crime, the best punishment for her is to go to somewhere else.
I agree, but do you think that in the past do you have the same thinking like now?
Sorry?
Because look, let's go back to the past,
Yeah.
when the implantation rate was lower.
Yeah.
I have worked in Germany for a long time, and we used to allow us to transfer up to 3 embryos.
But we're not then, we're now.
Let me
Yeah.
formulate the question in a
Yeah.
different way.
Yeah.
You are living in the past.
I'm not living in the past. I'm old enough. I'm living the present.
Let's say it
Yeah.
in a different way. How many cycles you transfer 3 embryos?
5%.
Two.
Two is, I do it the other way around, 80% single embryo transfer. And that's nationwide, by the way, not my clinic. 80% single embryo transfer. You know what is the multiple pregnancy rate in the UK? Under 5%. I'm quoting you the figure of 2019. Figures of 2023 are likely to be lower because it is a culture. When you transmit that message, honestly, there are patients whom sometimes I see based on the quality of the embryo that maybe not a bad idea to give her two. The patient will insist on having one. It's a culture. Either we nurture what is good or we nurture what is not so good.
That's what makes our life very difficult here.
Well, can I really
We
here
need to jump
go in?
to the
I do
last-
transfer twins in quite frequently. I do transfer to embryo, especially if patient say had previous failed cycles, 2-3 cycles. If the patient is over 35, if the quality of the embryos are suboptimal, I mean, there is circumstances where I find 2 embryos are the best. And the second point I would like to make, the risks for multiple pregnancy for twins are exaggerated really, because you always compare the risk of twins with the risk, one pregnancy of twins with the risk of one singleton pregnancy. But that's not exactly right, because with twin pregnancy, you're having 2 babies. So if you want to compare the risks of twin pregnancy, you compare it with 2 singleton pregnancies. Because in practice, if you want 2 babies, you have to go through double the cycles, you are exposed to double the medication, double the cost, and at the same time...
But this argument just needs common sense to make it null and void. Why? If you are comparing 2 flights to across the Atlantic in unsafe plane with, one flight with unsafe plane to 2 flights with a safe plane, there is no comparison.
It's not exactly
a
a very, I don't think that's a very, very good example, really.
Because where else would you get 10% risk of prematurity, of early prematurity? You will not get it with singleton. So your comparison is null and void.
I mean, remember when you put single embryo, you may get twins as well.
No,
I mean,
no,
I
that
know
is-
that's
that is
a
again
small
another,
one.
Sorry,
Yeah,
dysfunctional
but-
argument.
Yeah.
Situations that doctor, please implant 2 embryos, this is my desire. We are healthcare providers. We should be directing them for the right health decisions, all right? In today's day and age, when we are doing genetic screening of the embryos with an amazing AA quality and having 2 or 3 embryos in the freezer, I think one at a time, achieving 1 baby at a time is the norm. This is the era of elective single embryo transfer. Yes, once upon a time, when we never used to do a genetic screening, we used to put 2 or 3 embryos to maximize the chances of implantation. And that is why we used to have twins and triplets. But today, you see the rate of twin pregnancies or triplets have gone down. Why? Because we are replacing one single euploid embryo, making sure that it is a very holistic approach to the pregnancy. The woman is safe, her health is safe, the baby is safe, and we are safe. And
in practice, you are increasing the cost of cycle.
No, it is
When
not
you
about
do
increasing the
single
cost of cycle.
for
If I
3
have 2
times,
embryos and if I'm replacing
the patient
one,
may not
the patient,
have enough fund
the patient
to do
can
second
go back
or third
home.
cycle.
The patient can go back home with a reassurance that if the first embryo does not implant, she can always come back to implant the second embryo. She is not in a rush to
Free
start
of
another
charge? Free of charge?
That is secondary.
So she has to pay for it.
Yeah, it is cheaper than
Explain this to you. This is going to be cheaper than having the twins, 10% premature, going to baby care unit, stay for 1 month, and they come out with a bill like 1 million dirhams.
Not just that. I remember
With complications.
I remember I had
Lifelong
a patient.
complications.
I remember I had a patient from the Gulf region who was a pediatrician by chance. But in her defense, she had about 6 failed cycles before. So she insisted, that probably 10, 15 years. She insisted on having 2 because of her painful experience. We said, fine, we will have to be compassionate. And sure enough, she had twins. She had both her twins at 27 weeks. I can tell you the amount of money that the Kuwaiti, to be frank, the Kuwaiti embassy paid to the neonatal care at St. Thomas's Hospital probably financed the unit for 10 years. So it is. Back to your question, you're making an assumption that the only way to do single embryo transfer is to do PGTA. That could not be further from the truth. Why? In the UK, where we have 80% single embryo transfer, do you know what is the uptake rate of PGTA in the UK? With a bit of generosity, 5%. 95% is not done. So we should not link our practice to making it the norm. PGTA is not essential for life, and that is for tomorrow.
Now you are flipping, you are flipping the table again for the second time, because you said before about the endometrium, no era, so you flip the table. Now you are flipping the table for the PGTA.
Can I just add one very short comment? If you have a good cryopreservation program in your clinic, you don't need to transfer 2 embryos, period.
Disregarding the age of patient, disregarding quality of embryos.
Believing in the principle. Nobody said disregard the patient age. Make it your policy to start by doing. Ethics is all about doing what is right, not what is easy.
No, it's not. I mean, 42-year-old. Is it the same like
42,
30?
you will be lucky for her to get pregnant with anything.
Okay, that's the point.
Right. I don't think in ethics, there is something clearly right or clearly wrong. There is always a gray zone. It's not I'm with twins, but I happen to have 2 subspecialties. I'm subspecialized in maternal fetal medicine and in reproductive endocrine and infertility. And I believe that the risk with twins is there. It's definitely higher than singleton, but it's overrated. It's not as high. I mean, the example that Dr. Yaqub mentioned, the 27 weeks delivery, is not necessarily due to, I mean, yes, twins has part of it, but twins' average gestation age at delivery runs between 36, 37 weeks. That patient was unfortunate that she had her baby at 27 weeks. She had a singleton. She might have delivered that baby at 30 weeks, which probably would have been a better outcome. But if she had a singleton, she wouldn't have delivered at 40 weeks, that particular patient who delivered at 27 weeks. So I think just the issue of the twins is a bit overrated. It's higher risk, no doubt. But the one more thing, just you see, to answer these questions, it's very complicated. You have to look into ethics, patient well, who's paying, what's her background, how many failures she went through, the age, the fact that the single embryo transfer, who's going to pay for her second cycle? To come back for a second cycle, who's going to pay for it? To do a single embryo transfer with PGTA, who's going to pay for PGTA?
Dr. Fawaz, sorry, but the risks of twins is not overrated. You've got bleeding, you've got miscarriage. Everybody here is talking about one aspect, which is prematurity. You've got this, she's paid her life savings to do this. She got bleeding, she got miscarriage. Actually, she got diabetes and high blood pressure. Going to prematurity, neurodevelopmental deficit that is there. It is not overrated. All you have to see is one patient that had the twin journey, and I know there are members in this audience who've come up to me and said, yes, this is my story. It is not overrated, because the amount of money that is going to be paid to look after either the medical problems, after special care baby unit, or looking after the neurodevelopmental issues that are with these children in the future, she can have 3 or 4 IVF cycles if needed.
I counseled them about the cost of diapers and milk as well. I counseled them about the higher divorce rate with twins. I counsel them about all the details, and I make them make their own decision, and I support it with care and to avoid multiple pregnancies, but not necessarily twins.
Reality, we are really very happy in UAE that we have a drop, definitely a clear drop in the twin rate. We don't see any more triplets, so I think we are on the right track. So I believe the near future for us here in our community will be a single embryo transfer. I believe so.
Yes, these important issues should never, again, be left to individual judgment. This is a public health policy, and it depends on what attitude a country has to public health. A decent country will always prefer prevention rather than cure, will never take risks with lives. And one neonatal death, one late intrauterine death that could have been prevented for decent society is one too many, because there is a lot of suffering and misery for a couple where human lives matter. But if for us as individuals, we deliver the service and we forget about, I'm not suggesting you do, or anyone does in the audience, we forget about the consequences, we are really missing a trick.
Thank you very much. I think we can discuss for hours about this, different opinions, which is actually healthy to discuss about, but we have to move forward. Our next...
I will tell you the summary of the voting for the interventions. If the patient wants, heparin is the most chosen as approved for when patient has recurrent implantation failure from the audience. ERA is only 15% choose to do ERA, so I think you were successful. Aspirin, 92% choose to give aspirin. What else you can go? Steroids, 50-50. Intralipid, less than quarter, give. Intravenous immunoglobulin, 17%. This is ERA, okay. Next. BRB, least 8%. Endometrial scratch, 50-50. I think this all the mentioned intervention. If you have one comment, or Dr. Macklin, you have one comment on this? Fast comment.
Well, very fast.
Yes.
ESHRE has just come out with a very good guideline on add-ons, and I think everybody should read that because there is absolutely no evidence that any of it works. Short?
Can cause harm, I think, heparin. I mean, at the end of the day, you can get hit with heparin. Sorry. Yeah, it's the same concept. I mean, with heparin as well, lots of doctors or clinics use heparin when in fact it can cause also complications. It can cause hit, it can cause bleeding, increase the chance of also prematurity if you have to time the delivery in order to avoid a spontaneous delivery on someone who's on heparin so that you can give her an epidural and so on. So I think it can cause harm as well. And yet you see it used enormously, I think.
Okay, everyone should give a short comment about all this because this is very, very tricky. Please.
I personally, without oversimplifying matters, people should really examine their conscience, examine their knowledge, and examine their attitude. Because when you prescribe something, you must be able to satisfy yourself that there is biological rationale to start with. There is experimental evidence that it makes a difference. Now, we will all agree that recurrent miscarriage probably evokes more emotion than recurrent implantation failure, and people get desperate to use the weird and wonderful. Heparin of all agents and aspirin have been studied about maybe 15 years ago in a randomized controlled trial in New England Journal of Medicine was aspirin, aspirin plus heparin versus placebo. And the highest live birth, at least numerically, was with placebo. So what are we doing? Continue to give heparin. When you ask our colleagues in assist conception, why do you give heparin? Say it increases the blood flow. That is, unless if I'm mistaken and I have been absent from the world. Who said that? Heparin makes people bleed. It does not make them have new vascularization. Unless if we are really, really acting as if we know better than the intelligent design that created 8 billion people on the face of the earth. That's number one. Number two, those people who are bad in the UK, where IVF was originally invented, must come and learn how to use heparin. Because I go through life for years without ever prescribing heparin empirically. And I'm still practicing. I have a decent car, and I have not gone on the street basking to make my earning.
Thank you. Thank you very much. I think now we have to move to the next session because otherwise stay here the whole day. Thank you very much. Thank you.